Hello, I'm John Chabot. I lead a group of physicians and healthcare professionals who take care of people with complex pancreatic disease, and in particular pancreatic cancer. We're going to talk today about a specific subcategory of pancreatic cancer that we've developed expertise in managing and holds hope out for a lot of people with pancreatic cancer. When one looks at the distribution of people at the time of diagnosis with pancreatic cancer, more than half have disease that has spread outside of the pancreas. In that setting, surgery doesn't help people. Surgery slows down their progress to the right treatment, which is chemotherapy. So we work very hard to try to avoid surgery in that setting so that we can move people to the right treatment quickly. Only about 15% of people, when they're diagnosed, meet the traditional criteria for surgery of the pancreas. And what that means is it hasn't spread anywhere else, and it's not attached to any of the critical blood vessels that travel very close to the pancreas and feed organs that can't be damaged during surgery. Those organs are the rest of the intestine and the liver. If we damage those organs in a major way, then people suffer immensely. So it's always been considered inappropriate to proceed with removing pancreatic cancer, even though it hasn't spread, when it's touching one of those critical blood vessels. Those vessels in particular are the portal vein and the superior mesenteric vein. About 30 to 35% of people, when they're diagnosed with pancreatic cancer, have exactly this situation. It's a frustrating situation because we think the tumor is localized to that area and it would otherwise be amenable to surgery, but because of the dangers that have previously been thought to exist with working on those veins, it has traditionally been considered inoperable. We call that locally advanced disease. For about the last 12 years, we've been working on a program to allow surgery in that setting. We started off very slow in situations that were perfect, and more we moved to the more generalized situations, and at this point we attempt to treat almost everybody with locally advanced cancer with the aim to get them to surgery. The way we do that is we start with chemotherapy, sometimes we add radiation therapy, and then we plan the surgery. And we've been doing that long enough to have a very good understanding of what the outcomes are. And what we've proven is that in people who are appropriate for this approach, that their cure rates are essentially identical to people who are operable when they're first diagnosed with pancreatic cancer. And if you think about what that does, that tells us that we've now tripled the number of people that might be cured when they're diagnosed with pancreatic cancer, because prior to this, only 15% of people had a chance of being cured. And if we can now operate on 40 to 50% of patients who are diagnosed with pancreatic cancer, even if we're not curing a higher percentage of people, the fact that we can operate on a lot more people gives them an opportunity for cure.